We're going to talk today about the comprehensive behavioral intervention for Tourette's. My name is Doug Woods. I'm a professor of psychology at the University of Wisconsin-Milwaukee. And you might have been hearing a lot about behavior therapy for Tourette's or CBIT, and that's really what this talk is about. We're going to try describing it this morning. My intention of this next hour and a half is to get you to understand what behavior therapy is, why one might consider it as a treatment for their child, or themselves actually, because it's useful for adults, and then describe some of the evidence behind it and talk about some of the concerns that people often have about it, because I think it's important to kind of think about all of that together when making treatment choices for your child. I want to start with the behavioral model of tics. Now, I think it's important to understand why we're doing this, because I think it sort of demystifies it. A lot of times when people hear about the idea of using behavior therapy for a neurological disorder for, like tics, I think there's a lot of concern. Like, why would you do behavior therapy for a neurological condition? Does that really make any sense? Well, before we even start about why it really does make sense, I think it's useful just to think about that this isn't unusual at all, this idea. I mean, if you have a stroke, for example, obviously a neurological problem. After you have a stroke, are you always incapacitated the way you are right after the stroke happens? No. You recover a lot of functioning in many cases. And how do you recover that functioning? You recover it through therapy. What kind of therapy? Physical therapy, occupational therapy. And both of those are various forms of behavior therapy. It's repeatedly practicing a behavior over and over again, learning a new skill, learning to overcome a neurological deficit. This isn't anything different. Okay? OCD can be very effectively treated with behavior therapy. It's a neurological problem, and it can be overcome with behavior therapy. So the idea that behavior therapy is somehow odd for a neurological condition really is sort of old thinking. We know that behavioral procedures can change the brain. That's what they do. And so that's where the basis for this is. So let's talk a little bit about why this might make sense from a perspective of tics. Well, we know, and a lot of research and research dollars goes into understanding the brain and what's happening when people tic. What's the root problem, so to speak, in Tourette's? Now, I'm not a neuroscientist. I can barely pronounce half the words that neuroscientists say, and that's okay. I don't need to understand exactly what they're saying, but I can generally give you an idea of what the problem is. Think of the problem in Tourette's as something like this. You have this genetic predisposition that leads a certain portion of your brain, a part of your brain, to form not quite correctly. All right? Now, the part of the brain that gets the most attention, there are lots of different problems that happen, but the part of the brain that gets the most attention are the CSTC circuits, the cortico-striato-thalamocortical circuits. These are loops in the brain that control different aspects of behavior. Right? The S in that is the striatum. That has a couple different parts to it. We don't need to worry too much about what those parts are, but that striatum has a particular job. The job of the striatum is to determine which movements are appropriate for a given situation. All right? So imagine this. Up in the motor cortex of your brain, as part of your brain up here, are stored your movement signals. Whenever we want to do something, whenever we want to move, these cells get activated. These neurons get activated. These neurons send signals down into the basal ganglia, or the striatum. Okay. These cells, these signals that are sent down, are little pieces of movements. They're not full movements. They're bits of movements, parts of movements, okay? Parts of sounds, if you will. And these bits and pieces all get sent down for all the possible things we could be doing at that given time. Now, most of those signals are stopped because they're not appropriate for a given situation. Many of those signals, or some of those signals that are appropriate for that situation, get let through. They're allowed to proceed through, they connect in with the thalamus, and then they get executed ultimately as movements. All right? Now, what is a tic? A tic is a little bit of that movement that slips through when it shouldn't. All right? It's that little bit of movement coming from up here that goes through the basal ganglia, slips through when it shouldn't get through. All right? Now, in the striatum, we talk about how do you know whether something's should be allowed through? How do we know whether it's appropriate for a given situation? How do we know whether the striatum should block that little signal coming through or whether the striatum should keep that signal coming through? Okay, that's the question. Well, the basal ganglia also gets a lot of feedback from other areas. The striatum also gets feedback from other areas of the brain that are sensitive to reinforcement, sensitive to changes in the environment that come right after a behavior that tell the brain, hey, whatever you just did there, do it again. That felt good. So for example, if I have an itch on my body, I could be doing lots of things. I could be keeping my hands down, I could be scratching it, I could be looking over this way. All those signals are coming down into my brain. My brain says, hey, the last time you felt all that stuff, you scratched and it felt good. Do that again. Okay? And so that's the signal that gets allowed through, the one that goes like this. The rest of them get blocked. The head turning gets blocked. The putting my hands down gets blocked, and all that kind of stuff. So the brain, that striatum, is sort of like a gatekeeper. And feedback from the environment, when a behavior happens, if something good happens, that feedback says, hey, let whatever happened go through again. Or if something bad happens, the feedback is, hey, don't do that again. Stop it. If the striatum lets those motor signals go through and then stops or allows through, depending on the history of the situation, certain signals. So what is a tic? A tic is one of those little movements that get through, and then how the environment reacts to it is going to make a big difference as to whether it continues to go through again and again and again. All right? Now, all of this is happening outside of your awareness. You have no idea that any of this is happening. Okay, this is all subconscious, so to speak. All right? So that's kind of the basis for this. This is where we're going to start. That's what leads to tics. But we know, as I said, tics happen in the environment. There are environmental reactions to the tics. There are things that happen outside the person's body that after tics happen. There are things that happen inside the person's body after tics happen. And those two things, those two reactions to the body, to the tic, external and internal reactions, can make the tic worse than they need to be. They can strengthen the tic. Okay? All right. So let's talk about that. Talk about antecedents and consequences. When we talk about how the environment, both external environment and internal environment, how those two factors affect tics, we break them down into two groups. We talk about antecedents and we talk about consequences. Antecedents are things that happen before tics that make tics more or less likely to happen in a predictable way. So for example, places, situations. You can all think of, if you think of your child, are there certain situations or certain places where their tics tend to be worse? Everybody can kind of say, yeah, I can think of that. Are there certain people that they're around that their tics get better or worse? Yeah, you can usually think of that too. I've heard cases like, oh, my son tics all the time in front of my wife, but never in front of me, or very rarely in front of me. I hear that kind of thing. So you get people that can push tics around predictably. Activities. My kid's playing sports, he never tics. Or he's playing video games, he never tics. He's sitting there doing homework, he tics like crazy. He's in school, he doesn't tic. He's at home right after school, they blow up. I mean, on and on and on. These are very reliable, predictable things. And you all know they're there. I mean, I'm sitting out here and I'm watching heads and smiles and like, yep. And so we all know that that's true. There's also internal experiences. You know, ask your child, if you haven't already, do you feel the tics coming on? Either a little tightness in the area where the tic's happening or more of a global feeling throughout your body. And they're going to say, yeah, I feel it. I feel like, you know, it's building up and then it releases when I tic. Okay, that's another thing, that when that's present, that feeling's present, they're more likely to do the behavior. There are also consequences to tics. Consequences are things that happen after tics that make tics more or less likely to happen. These can be reactions to tics. So when people say something after a tic happens, like attention that they might get, or laughing from a peer, those kinds of things. Or it can be escape from things. And we'll talk about examples of that in a little bit. There was so let me back that up. We know that there are events in the world that push and pull tics. So that's one thing we have to consider when we're thinking about using behavior therapy for tics, that there are factors in the world that push and pull tics. We know that events in our own body can maintain tics. So, you know, we get this reduction of the urge that follows the tic. You know, they feel buildup of tension, they tic, and the feeling goes away. And we know that the point of behavior therapy is to change the environment in order to change the tics. So we figure out what these events are that push and pull tics. We figure out how to change this situation a little bit, and we'll talk about that in a little bit. And we do those two things together, and that's called behavior therapy. And how do we do that? We talk about changing antecedents, and we talk about changing consequences. What are some antecedent events that impact tics? There was a study done by Raoul Silva in 1995, and he asked a group of people with Tourettes. He had a list of things that could affect their tics. And he asked for each of them, he asked the group of people with Tourettes, does this make your tics better? Does this make your tics worse, or does this not affect your tics at all? I'm going to argue that this was actually, for its time, probably one of, if not the most important behavioral study ever done in Tourette's. Dr. Silva disagrees with me, but that's his own study. But here's why I think that. He found this. When he asked about being upset or anxious, he said he found a large group of people with Tourette's found that being upset or anxious made their tics worse. A smaller group said it made their tics better, actually. Being anxious or stressed actually improved their tics. And a third group said it didn't affect their tics at all. Watching television. For some, it made their tics reliably worse. For some, it made their tics reliably better. And for others, it didn't affect their tics at all. Being alone. For some, it made their tics worse. For some, it made their tics better. And for some, it didn't affect their tics at all. Being around other people. For some, it made their tics better. For some, it made their tics worse. And for some, it didn't affect their tics at all. Now, you might be thinking, why on earth does he think this is so important? It seems kind of like maybe Dr. Silva was right. Maybe this study wasn't so important. But I would argue that this study sent two very important messages at a time where there wasn't much recognition that the environment could influence tics. And here's what the message it sent. First of all, that these people with Tourette's could tell you exactly what was pushing and pulling their tics around. They knew when it was happening. They knew what factors were hitting them and making their tics harder to control, harder and more frequent. The other important part was that everybody was different. The factors that impacted patient A were very different than the factors that impacted patient B. And what that tells you from a therapeutic standpoint is A, if you change the environment, you may actually be able to reduce some tics, and B, that you're going to have to take an individualized approach to it. You can't do just a one-size-fits-all thing. It's got to be done in an individualized way. We have seen other things too. Stressful life events can alter tics. Hearing other people cough can talk about tics. Talking about tics can make tics worse. We know that, and we've shown that experimentally. And we might think about, all these things. Tourette's seems sometimes like a really bizarre kind of condition, but it's really not that far out of normal. It looks like it is, but it really isn't. It operates within our brain that pretty much is, for most parts, intact. So what do I mean by that? Like this whole idea about talking about tics. How can talking about tics make tics worse? Well, we all have a little bit of that. I mean, we're all that way to some extent. Maybe not with tics, but with other things. So if I go like this, how many of you want to yawn? Okay. This is a perfect example. How many of you did yawn? About 5% of you who actually wanted to. And so you had the same thing, those neurons up there that tell you, hey, mimic, they're called mirror neurons, mimic what other people are doing. That's a good thing. They fire off, they send the signals down to do something. Your brain knows, don't do it this situation, not appropriate for this situation, and it stops it, it inhibits it, okay? And then you don't yawn. A person with Tourette's yawns because their brakes don't work. That part of the brain, the striatum, is about 5 to 10% smaller in volume. The dopamine system in there that is supposed to be there for regulating it doesn't work so well. So they would do the same thing you would do. It's just the part of the brain that's supposed to stop them won't do it. Okay, so that's really kind of what's happening. So it's not unusual that these kinds of things occur. Premonitory urges are another antecedent event that makes tics worse. When this feeling is there, the tics get worse. And what is a premonitory urge? It's that feeling that you feel right before you have to tic. If you want to, I forget who it was, I had a patient once who told me the best way to understand what a premonitory urge feels like is to open your eyes really wide and don't blink. Just stretch them out. Do that now if you can. And feel that feeling around your eye. And pretty soon you'll be feeling some kind of weird, I don't know how to describe it, around your eye, and then go ahead and blink. And you'll notice it goes away. Kind of goes back to normal. Okay? Think about feeling that, being bombarded with that constantly. That's kind of what a premonitory urge would feel like. And then it would go away. And what would you want to do? I mean, you'd want it to go away because it stinks. It doesn't feel good. And so you start getting that behavior that takes it away, and you do it more and more and more because you're bombarded by these urges constantly. What about consequence events that can impact tics? Well, consequences, reactions to tics, can make tics more frequent or less frequent. How can they be made less frequent? How can tics be made less frequent? Well, everybody with Tourette's has the ability, at least many people with Tourette's, have the ability to suppress their tics for short periods of time. Okay? We all know that. They can kind of hold it back for a short period of time. That behavior is something that could be reinforced, could be strengthened. And what kinds of factors go into strengthening the reduction of tics? Well, why do people suppress their tics? They avoid being teased. That's a reinforcer. They are able to do social activities or sports that they may not have been able to do, so they try to hold their tics back for a short period of time so they can do that. They can avoid being embarrassed. They can ask the girl next to them out on a date. They can do, there are all kinds of things that they can do that anyway, but they kind of think that they can't, and so they reinforce the suppression. But we can also, and also, by the way, you've got to wonder, I hear this a lot as a clinician. My kid doesn't tic much in school. In fact, when I told the teacher he had Tourette's, they were like, really? Really? I would have never guessed. But when he comes home, it's just tic from the minute he walks in the door to the minute he goes home, or the minute he leaves again. So, why is that? Why is it that he's not ticking much in one situation than another? Maybe there are different consequences for the tics in certain situations. Maybe there's a lot of reinforcement for not having tics when he's at school, for example. What about making tics more frequent? Social reactions. Well, after we tic, a lot of times there are social reactions that can happen. There was a study by Watson and Sterling that found, they were reporting on the case of I think a 7 or 8 year old girl. And this girl had a number of tics, but one of the most bothersome tics was this repetitive coughing tic. And they found that it happened most at the dinner table when the child was eating dinner. That was when it was elevated the most. So they went in and watched the interaction between the parent and the child in this situation. What they saw was something like this. Stop it. Can you be quiet? Can you just please give us a few minutes of quiet? Stop. You're going to have to go. You're going to have to leave the dinner table. That kind of interaction. That was it, pretty much throughout the meal. So Watson and Sterling had this assumption that maybe the parent's reaction to this wasn't helping. Okay? Maybe what we need to do is do something like this, where we say, you know what, from now on, ignore the tics, don't react to them, and talk to her about her school day. Nothing else, just about what she likes to do, what she did that day, whenever she's quiet for like 30 seconds. So if she gets a period of 30 seconds in there, even if her mouth's full of food, and that's what's making her quiet, for 30 seconds, when she's quiet, then talk to her about her school day. Because right now, before treatment, there was nothing, no talk about anything but the tics. And so they did that, switched it, and within 3 days, that tic was nearly gone. Okay? Now, it still was there because the biology hadn't been fixed, but the environmental effects, the effects of the learning there, had been scraped off. All right? So this kind of social reaction can make tics worse than they need to be. Not that they cause tics. They do not cause tics. You don't learn to tic. But the environment, the reactions to the tics, can make the tics worse than they actually need to be. All right? Think of it this way. Now, if you're a parent of a child with Tourette's, which most of you are, you have a child with a very violent head jerking tic, and it seems to happen most often when he's sitting next to a wall, and he kind of likes that feeling of the smack of the head into the wall. If you're a child, if you're a parent of a child like that, and you see your child starting to do that, and they're going like this, and their neck's hurting, and they're rubbing their head, maybe crying a little bit, and it's getting really tough. If you have any kind of soul as a human being, and if you want to have any decency as a parent, your first reaction should be to go over to your child, hold them, make sure their head's safe, tell them it's okay, tell them you're going to get help, maybe cry with them a little bit, rub their back, all that kind of stuff, that good parent stuff. That should be your natural reaction, all right? A lot of love, a lot of attention, just heaping it on right there because you want to protect them, right? Kind of get that. Now, my question is, when they're not ticking that much, do you do the same thing with the same intensity? And you can admit it, you probably don't, okay? I'm a parent of 3. I don't, okay? When my kids are quiet and not beating the hell out of each other, then I'm not there. I'm silent. I'm getting other things done. I'm thanking God that they're not beating each other up anymore, and all is good. In fact, I don't want to interfere at that point. Whatever's happening, it's happening right, and I shouldn't be involved. When I get involved is when the problems start, right? And so if you think about that from the perspective of your child, now again, your child isn't thinking about this consciously. It's not something they're aware of is happening. They haven't put it together. But what's happening is they get a big bunch of tics, and mom and dad show up and give a bunch of attention, love, hugs, kisses, all that kind of stuff. When I'm not ticking, just go about my day. Okay? I mean, you think about it. Nobody's doing anything wrong in that situation. It's just, is that the best situation? Is that the most useful way to approach it? Where the tics get all the attention and the quiet doesn't. Is that the most useful way to approach it? Now, I'm not saying let your kid, bang their head into the wall until they go unconscious. I'm not saying that at all. You always have to keep them safe. You're never, ever putting your kid at risk. But there's a way to keep them safe in that situation and not really react to it. And then there's a way to react to it. So that's what I'm talking about here. There's also peer attention. Imagine the child who doesn't have many friends, and they start doing a tic in class that gets a lot of laughter from the peers. Is it safe to assume that might actually make the tics a little worse? Now remember, the child's not thinking, I'm going to tic so I can get my peers to laugh. That doesn't have to be the case. Remember I said the basal ganglia, the striatum, that lets stuff through subconsciously. So the tic slips out, that little, slips out, and the reaction from the peers is laughter, and that feedback gets sent back to the striatum and says, hey, let that through again. That was good. Let that through again. Now, this isn't happening consciously. It's just happening. All right? So is it safe to assume that peer attention could make this a little worse than it needs to be? Potentially. Escape from an aversive situation. Imagine this. Child sitting there, third grader, in class, and the teacher says, okay, we're going to walk around, we're going to take turns reading. So I want everybody to stand up when it's your turn and read a paragraph and then sit back down. Okay? So you've got the child who doesn't read very well, but he's got a loud vocal tic. And for those of you with Tourette's in the audience, I'm going to mimic some. This will probably bother you, so close your ears or something if you don't want to be feeling a little more ticky than usual. So the child stands up, and it's his turn. He doesn't read very well anyway. He starts comprehensive behavioral intervention for tics. Part one. The teacher's all uncomfortable. Kids in front of him are uncomfortable. The kid himself is embarrassed. What does the teacher do? The teacher does what we always tell teachers to do. Why don't you just put that down, go to the nurse's office, get your tics together. When you calm down, you can come back in. Thank you. Go ahead. That's okay. Don't worry about it. Teacher's doing what the teacher needs to do to preserve his own feeling. I mean, the teacher's taking care of the student. The teacher's taking care of the other kids in class because he's trying to make sure the other kids can learn. They're taking care of their own sanity in a little way, just because it's like getting too emotional and intense for them. So they do that. And most of that is right. Most of that is okay. But what's the one wrong thing they did there? Reinforce the behavior. In what way did they most importantly reinforce it? What was the worst part of that move? The worst part of that move was, you don't need to do your work anymore. Go. The go wasn't bad. The go was okay, actually. The worst part of that was, put the work down. You don't have to have any responsibilities if it's too hard for you when you tic. That's not a good message to send. That's the wrong message to send in a lot of ways. What would have been the right way to say this, in my opinion? Why don't you take that reading and you can go to the nurse's office. If it's tough to cope right now, I get it. Bring that work to the nurse's office, and you can do the work with the nurse. That's wonderful. Your life's not going to change. We're not going to let you out of responsibilities because you have this tic. You still have to do the work. Maybe we'll have to change how you do it or make it a little different for you to accommodate for you, but you're not getting out of it. And that's the dangerous road, because everything the way we would normally act naturally, that all of our instincts to protect our kids sometimes work against us in this way. And so we have to be careful. We always want to protect our children, but we want to do it in a way that teaches them that the tics are not a ticket out of anything. They don't we may change how we do it, but they're not an escape valve, so to speak. Okay. The reduction of the premonitory urge as a result of the tic. And this is an important one. Remember, people talk about this urge building up right before the tic happens. The tic occurs, and then people experience relief. So it's like an itch on your body. You itch, you scratch, and you get relief. Okay? The next time you itch, you're more likely to scratch quicker because it feels good, feels relief. Think about your alarm clock. The first time you get a brand new alarm clock, except these iPhone alarm clocks. I still haven't figured out how to turn those off. But you get a new alarm clock, and the first time it goes off, beep, 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 you turn on the light, you look around, put your glasses on, try to figure out where the off button is. You just start banging around until the thing shuts off. All right? Takes maybe 2 minutes to turn the thing off the first time. Next day, a little faster, a little faster. 2 weeks later, beep, poof, you don't even have to open your eyes. You know exactly how to reach out and smack it. You've gotten better because you've learned that behavior takes away this negative thing. And you get faster, you get more efficient, you don't let the alarm go off as long. All those things happen. And the same thing is true for urges. People who've had tics for a long time and have learned that the tics take away the urge, they tic at the slightest detection of an urge. It's like that urge just creeps up a little bit and boom, there it is. Because they know they don't want it to get too big, they don't want it to get too bad, take it away quickly. Okay? So you get this repetitive, sort of habitual sort of activity. A little bit of an urge shows up, the tic happens, urge goes away. A little bit of an urge pops up, the tic happens, the urge goes away. Now the people with Tourette's aren't aware of it. They don't know a lot of times that this is even happening. Okay? But if you probe, you find out that it does. Okay? So again, to develop intervention, we take that basic background knowledge and we realize that the effects of the environment are unique to the individual. To develop a useful treatment, both the external and the internal factors must be addressed. External factors need to be addressed through what we call function-based intervention, and we'll talk about that. And internal factors need to be addressed through habit reversal, which we'll talk about as well. Let's talk about function-based interventions. This part of treatment, what we call function-based interventions, the purpose of it is to identify the environmental events that exacerbate or maintain tics for a given child. You'll notice I didn't say cause tics. I said exacerbate, like make worse, or maintain, keep tics going when maybe they normally would have faded away. We find what these events are, and then we modify them in order to reduce tics. Okay. So what does this look like? Imagine this situation. What we would do clinically is something like this. So we would interview with the parent and the child, and we would sit down and we would ask them, think about your child's tics in the last week, maybe the last couple weeks. And we're going to talk about a lot of different situations that could make your child's tics worse, that reliably make your child's tics worse. Can you think of times in the last week when your child's tics just generally happen more frequently or more intensely? And the mother thinks about it, she says, you know what? After school, every day, that's when they're most likely to happen. That's when they explode. And so what we do as a psychologist is start looking for patterns at that time. What's happening in the environment at that time that we think might be associated with the tics getting worse? So I start asking mom, well, tell me about after school. Tell me the typical day after school. And the mom says, okay, well, I'm a single mom. I've got 2 kids. All right? I get home from work about the same time they do. My daughter goes downstairs. My son comes home a little bit later, like 5-10 minutes later. He comes home from school and he's stressed out and anxious. His tics are always worse when he's stressed out and anxious. He's been just uptight about school all day. So he goes to the den where his sister's watching television. The den's in the basement. And she's already down there watching TV. And he starts ticking. He does a lot of loud vocal tics when he's down there. That's one of his big tics. And they really just explode right after school. This gets his sister upset because she can't hear anything. She starts teasing Billy, gets really angry at him, and then starts making fun of him. And then pretty soon he gets upset, and he's crying pretty soon. He's a little bit younger than she is. And so she starts crying, or he starts crying a lot. I hear this. I hear them fighting. So I go downstairs. I was trying to make dinner. I go downstairs, and I send his sister out of the room. I look at her, and she's being mean to Billy. I just can't stand it. I send her out of the room, and I look at this poor kid, this 8-year-old kid. He's crying. I feel bad. It's probably my fault because my dad had this, and I probably gave it to him. And, so I feel bad. I feel guilty. I feel like I want to help him. I feel like I'm not doing enough. I feel like I'm a bad parent, blah, 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 blah. So I go up to him. I hug him. I tell him it's going to be all right. I rock with him. I tell him I'm going to get him help. I calm him down. I say, why don't we have a good rest of the night, watch some TV, relax, and when you feel like you can do it, we can have dinner and have a good night. All right? That happens 4 nights a week, at least. Okay? So as we're hearing this, we're thinking, we're breaking it down. We're thinking, what are the antecedents? What's happening right before the tic that could be making this tic worse? And there are lots of things in here. And then we also think about what are the consequences? What's happening right after the tics, reactions to tics, that may be making the tics worse than they need to be. And so what are some antecedents? Well, Billy's anxious. That could be something. That's when he gets hyped up, his tics happen more. It's also when he's in the den. When I talk to Mom a little bit more, I find out that, when he goes outside after school and plays outside, his tics aren't as bad. When he helps me cook dinner, helps Mom cook dinner, his tics aren't quite as bad. But when he goes in that den and just sits there, it gets worse. Okay, so that's an interesting thing. And Mom can tell me that, so I take that information. Consequences. What's happening right after the tics happen that could be making the tics worse than they need to be? Could be. I'm not saying they are, but they could be. Well, what changes right after the tics happen? Billy's sister gets sent to the room. Okay, now that's an important one, because if you understand how siblings relate, one of the greatest joys in any child's life is to see their sibling get into trouble. I mean, that is like wonderment to them. My middle son goes out of his way to get that entertainment. He'll set up that entertainment. His teasing sister gets sent to the room. There's a little bit of juice to that. Billy gets the mom's love and attention. Mom's a single mom. She doesn't have a lot of time. But when, the one time she gets a chance to get really close to Billy, is that time. She tries to put him to bed and everything, and she might get it there too, but he gets a big, heavy dose of love and attention when there's this big burst of tics. Billy gets the TV to himself, so he doesn't have to watch Hannah Montana anymore. He gets SpongeBob back on. So there's something there too. Now, is that to say Billy is a budding little psychopath who's out to control his world through tics? No, not at all. Not at all. He doesn't know this is happening. We always learn things out of our own awareness. Our brain does not need us to be aware of anything for learning to take place. So if we have that, what might we do in terms of intervention? Well, if we think anxiety is making his tics worse, we'll teach him relaxation strategies. Very quick, simple relaxation strategies that he can use in situations where he's stressed out. And that will help him control his tics when he's relaxed in stressful situations. So we'll teach him how to do that. Instead of having so much downtime in the den, we might schedule activities after school. Get him outside to play. Schedule a play date after school. Have him help in the kitchen. Or limit the amount of time he's just sitting there right after school if that is where his tics get worse. What are consequences? Instead of having the teasing sister sent to the room, we don't let her leave the room. We ask her to apologize. Maybe we bring her into the therapy sessions to let her be part of the treatment plan too and help out her brother. Instead of Mom comforting Billy, we say, look, we want you to pay attention to your child. We want you to love your child. We want you to provide affection to your child. Just don't do it in great big doses when he's having a lot of tics. Do it when his tic time is down. Make a special effort to go spend 5-10 minutes of very close time with your child when he's at a kind of a reduction in tics, like when the tics are a little bit lower during the day. When that time is. Maybe it's right away in the morning. Maybe that's when he's not ticking so much. Spend that time with him then. That's when you give him the hugs and the kisses and you make that effort to spend that same amount of time that you normally would have spent during a big tic outburst, spend it when there's tic downtime. Okay. Billy getting the TV to himself, contrary to what most children will think, they will not die if the TV or video games go off. So you can always reduce that amount of time and limit the amount of time they spend in those high tic risk times. What about this other factor? How do we deal with this? Because this is a tough thing to treat. Because this is kind of like happening all the time for a person with tics. Those that reinforcement for ticking, the reduction of that unpleasant feeling, comes almost every time the person tics. So how do you get rid of that? How does that go away? Well, that's tough to do, actually. But one of the things we've been able to discover is this, that when the urge happens, when that urge to tic pops up, if you're able, not everybody's able, but if you're able to block the tic and hold that for long enough, what happens is the urge fades away. Okay. Not for everybody. Sometimes it takes a long time to happen, but the urge fades away. And the more you practice that, the better you get at it. And the faster the urge fades away. Okay, we call that a process called habituation, and which is when you suppress something in front of the urge itself will start to go away. Now, that usually freaks people out. Well, you're telling them to suppress his tics? Kind of. I'm not talking about the kind of suppression you might be thinking of, though. The kind of suppression you think of is what your child does in school when they don't want to have any tics, which is something like this. Don't tick, don't tick, don't tick, don't tick, don't tick, don't tick. and like nothing's getting out. That's not at all what I'm talking about. I'm talking about focusing on one tick at a time. I'm talking about doing it in a very easy way. You know, it's not easy to do, but like in a very controlled way. Not this, all my mental effort, all my attention must be focused only on this. It's a very different kind of procedure. We use something called habit reversal training. And habit reversal training, we believe, does create habituation to the premonitory urge, and it's designed to disrupt a habitual motor pattern that has already developed. What is it? It's an older treatment. It's actually been around for almost 40 years now. It was developed by a couple behavioral psychologists. His name was Nathan Azarin, and his student Gregory Nunn. Developed this in 1973. Now, many of you may not know Azarin's name. Most psychologists don't even know Azarin's name. They should, but they don't. But my guess is you've heard of things Azarin has had a really big role in developing. Azarin was a psychologist who worked with B.F. Skinner, the famous behavioral psychologist from the 60s and 70s. Azarin was a rat-running, pigeon punishment guy. That's what he did. He did basic behavioral research in universities. And at some point, he had a change of heart, and he wanted to start doing more clinical work. And he started developing clinical treatments based on what he learned in the labs. And a couple of the treatments that he's had a big hand in developing, like you can almost say he's the founder of them. Have you ever heard of timeout? That was Azarin. Have you ever heard of something called token economy or sticker charts? Yes. That was Azarin. So these are core parenting things now. They're not like, crazy things. We all kind of do these things. And Azarin was really kind of at the forefront of developing this. He was kind of one of the founders of behavior therapy. And this is just one of the little things that he developed a long time ago that's been tested actually for a long, long time. It had three main components: awareness training, competing response training, and social support. Awareness training is to teach the child, we treat one tick at a time, by the way. We don't ever try to treat all ticks at one time. We try to treat ticks from the most bothersome tick to the least bothersome tick, and we go one tick at a time. And we start with that first tick, and we first teach the child to become more aware of it. All right? Now, everybody with Tourette's syndrome knows that they have tics, but they don't often know when they have tics. There's a big difference. You can know that you have tics, but you don't always know when you have tics. Now, some people do. Some people are hyper aware of it. But many times, people think they're more aware than they actually are. All right? So the first thing that we try to do is to teach kids to be more aware of when they're ticking. Now, some people get concerned and say, wait a minute, if you make your kid more aware of it, isn't that going to make their tics worse? The answer is no, if you do it the right way. There's a difference between becoming self-aware and becoming self-conscious. Okay? Self-awareness is created when you point out to people that they're doing something in a very non-threatening, non-punitive way. Okay? That creates self-awareness. That gives you the basis for changing things. Self-consciousness is brought about by a very different history. Self-consciousness is brought about, basically what self-consciousness is something's pointed out to you in a very negative way. You become aware of something through negative consequences. Okay? You get punished or yelled at or screamed at or belittled or made to feel stupid every time a behavior occurs. You'll become more aware of that behavior and you will feel bad that you are doing it. That's self-consciousness. Making someone self-conscious of their tics probably makes them worse. Making someone self-aware of their tics makes them ready for change. And so there's a difference there. We focus on enhancing self-awareness. We also do, then, after we train them to become more aware of their tics, we do something called competing response training. Competing response training is teaching them to do something that physically prevents the tic from happening, and they do this behavior for a minute or until the feeling goes away, whichever takes longer. Every time the feeling shows up, the urge shows up, or the tic itself happens. So it would look something like this. And we would do awareness training. We teach the child to be more aware. And actually, the next session, I'll show you how that looks, what it actually looks like. But we teach you to be more aware of the tic. And it would say, every time you do the tic, we want you to do a competing exercise. Now, we'll pretend we have a child with a neck tic, like this. And so every time the child feels the urge in the back of the neck, or even starts to do the movement, we would say, we want you to do a different movement. What I want you to do is, we're going to call them your exercises, and I want you to put your chin down slightly and tense the sides of your neck. Just really gently, not so much that it hurts or shakes or anything like that, but just gently tense the side of your neck. And I want you to hold that position for a minute or until the feeling goes away, whichever is longer. At the end of the minute, you ask yourself, is the feeling still there? If it is, you keep going. If it's not, you let go. Okay. So the kid does this. At the end of the minute, the feeling's gone. Then they just kind of relax their neck and go on. And then the urge comes back, and they're right back to this. All right. They would do that over and over and over again. Now, a couple of things that people get concerned about. They ask, wait a minute, does the urge go away? Does it really go away? And the answer is, for most people, yes, if you wait long enough. Sometimes the first couple waits are really long. I'm talking like an hour and a half, you know. That's very rare, but that can happen, all right? I can remember a case that we had. It was a person who had a very violent neck shaking tic. And he came to our clinic and he asked, you know, he had tried a lot of different kinds of medications and a lot of different kinds of things, considering deep brain stimulation at that point. And he came in and he was meeting with one of our therapists who was actually brand new. He had just started. Okay? And the guy was talking about it, the patient was talking about it with the therapist, and I was behind the mirror watching the session like I usually do when I'm training new therapists. And this guy said, you know, I'm doing this, and I'm at the point where my physicians have told me I'll be paralyzed if I keep this up. I mean, it'll eventually cut into my spine, and that'll be it. I mean, I'll lose all feeling in my arms and potentially legs. And my student asked him, well, how many times a day are you doing this violent neck jerking thing? And the guy said, about 80 times a day. And it was just this really, you could hear snap, crackle, and pop every time it would happen. And so I looked at my student, and he was turning like 16 shades of pale because he was so nervous about what he was seeing in front of him. So I ran around and started to talk to this guy. And I said, look, you know, I want you to understand what we're going to do in terms of treatment, because I want you to understand what you're getting into before you actually start it. You've got a very serious case here. And I said, what we're going to teach you to do is to notice when you're about to do this tic. And I said, I bet you get a feeling in the back of your neck, you know, or somewhere around your neck before you do this. And he goes, yeah, it comes right up the back. And I said, okay, does it go away when you tic? And he goes, yeah, it does. For a short period of time, it goes away. I said, okay, what we're going to teach you to do next session, not now, but we're going to teach you to do next session is to notice when that feeling shows up and to notice when you're doing the tic all the time. He goes, believe me, I know when it's happening. I said, okay. Well, then what we're going to teach you to do is to do something that prevents that tic from happening whenever you feel like you have to do it. And what we're going to find is that feeling will probably go away over and over. If you practice it over and over and over again, that feeling will go away faster and faster and faster. And he said, that feeling goes away? That was his first question. That feeling goes away? And I said, well, in many cases, yeah, it takes a long time sometimes the first time, but if you practice it, it goes away faster and faster. He said, okay, well, I'll think about it and I'll give you a call for next week. So he called next week, and again, I was behind the mirror, my student was in the room, and my student asks him, so how'd the week go? Ready to get started? He said, you know what, the week was awesome. And he said, well, you know, how many times did you tic? And he said, 5 times. And my student said, 5 times a day? That's great. Down from 80. And he goes, no, 5 times the whole week. That was it. And the 5 that came out looked like this. And so I ran around the room and wanted to find out what was happening, because we hadn't treated anybody yet. We hadn't done anything yet. And so I asked him, I said, what? We didn't, you know, I like to be able to help people without doing anything. I mean, that's great. If I could just wave a magic wand, but it seems a little unrealistic. What happened? He said, well, you know, I'd never thought about the fact that this urge could go away. And this guy was kind of scientifically trained. You know, he kind of had that mind about him. He wanted to test things, and he was skeptical about things, so he wanted to test it. He said, so, you know, as soon as I walked out of here, I had that urge run up the back of my neck. I felt it. And I decided, you know what, I'm not letting it out this time. Now, remember, people with tics can suppress their tics to some extent. They do have that ability in many cases. So he said, I wasn't going to let it out. And it got so bad. He said that feeling just got awful. It got awful and awful, and I had an hour-and-a-half drive home, but I would not let it go. And it went up and down a little bit, but it was still pretty bad. It was intense, but I would not let it go. And I just kept driving. And he said, I got home, I talked to my wife, and told her how the session went, and I went out into the garden, and then she came out, and we were talking. And before I knew it, it was gone. It was like maybe hour and 50 minutes after I left your office, it was gone. It just faded away. And then as soon as I noticed it wasn't there, it was right there. And I did it again. And you know what? It only took maybe, I don't know, hour, 10 minutes maybe that time, and it went away again. And I just kept doing it. And now it's not there. And when it does slip out, it's usually so fast that I don't even notice that it happened. It's just like that. It's like, oh, darn, I missed it. It's just, I don't have to do it anymore. The feeling has faded away. And that's, I think, the kind of the idea that we're trying to go after a little bit. Now, is it that dramatic for everybody? Of course not. And is this the magic kind of thing for everybody? Of course not. Anybody who tells you they've got something that's the cure, or anytime that there sounds like there's something too good to be true, there's something too good to be true. They don't have the cure. So, be skeptical always. But for many cases, this can happen. Yeah.
Does that work the same way with vocal tics?
Different exercise because you can't stop breathing, but but it's the same idea. Actually, that's an easy way to treat it. Hold your breath till you pass out, and then if you're ticking, you don't know it. And I guess that's the... So let's talk about habit reversal and the evidence. The evidence for habit reversal is extensive. There's more evidence for habit reversal in terms of raw numbers of studies than any medication out there for tics, by far. It's not even close, actually, because there's 30 years of data collection behind this. In 2007, it was determined to be an effective treatment by the American Psychological Association Clinical Psychology Division for adults with Tourette's. There have been a lot of different trials that have been done, almost all of them showing some kind of benefit. The problem with all of these trials have been that they've been very small up until this date. And they have been published in journals that most physicians don't read. And most physicians the physicians are the ones who are getting these kids originally. You go to your pediatrician, your neurologist, your allergist, all those kind of folks. Psychologist isn't the first person on your mind when your kid starts ticking. All right? So, we've got to think about where these things have been published. In about 2002, I think, the TSA had been getting a lot of questions, I think, would be the way to put it, suggestions from their membership about trying to come up with treatment alternatives. How do we come up, we've got some medications, but we seem to have hit a wall. We don't seem to have a lot of new stuff coming out in terms of treatment options. Do we have any non-pharmacological treatment options? Most parents are kind of hesitant to put their kids on medication of any sort at first. That's something they weigh heavily. Do we medicate? Do we not medicate? I just don't know. And I think if parents were given the choice between trying medication and trying something other than medication, I think they'd like to at least have that option. And I think the parents at the time were saying the same kind of thing. So the TSA went in and collected people from around the country who they knew had been doing some work in behavior therapy. And it's this group here. They brought us together and they locked us in the LaGuardia Marriott and said, you guys come up with an idea for a non-pharmacological treatment option, give us a path forward. And so we quickly, because we were locked in LaGuardia Marriott, came up with a suggestion for how we get some kind of non-pharmacological treatment option. We knew a couple things. We knew that habit reversal had to be a core element of this treatment, of any behavioral treatment, because we already knew that it had some power behind it. We also knew that habit reversal probably didn't go far enough because it didn't really address those kind of external environment things like reactions to tics or the situational variables that make tics worse. And we needed a systematic way to sort of address those too in treatment. So we combined habit reversal with those function-based interventions and a couple other things to create this what we called comprehensive behavioral intervention for tics, or CBIT. We proposed to do 2 very large studies. These are actually the 2 largest treatment outcome studies of any treatment where tics is the focus in Tourette's. So these are larger than any medication trial for where tics is the focus. And we developed a child study and an adult study. And we were going to compare behavior therapy to a psychoeducation and supportive therapy control condition. All right. We did these studies. We got them funded through the National Institutes of Mental Health, and they both basically had the same kind of design. We took them, we randomly assigned the kids and the adults into the CBIT or the control condition. CBIT was 8 sessions of treatment over 10 weeks, 2 90-minute sessions at the front, and then the rest were 60-minute sessions. We had somebody who wasn't the treating clinician evaluate them at baseline, in the middle of treatment, and at the end of treatment. If that clinician felt that they had gotten a meaningful response, gotten clinical benefit from this treatment, they were given 3 once-a-month booster sessions, reminder sessions. And then we followed to see how they did 3 months later and 6 months later. If they didn't respond to treatment, we didn't waste any more of their time. We let them go, and tried to come up with some other option for them. All right. These are what the treatment components were. You can see habit reversal, function-based intervention, psychoeducation. We had a reward system, but we never reward kids for not having tics. That's not the right way to go. What we reward is we reward them for being compliant with treatment, for working hard in treatment, for trying hard. And what the analogy I give to parents is something like this. I've actually had parents come up to me before. I've had a parent come up to me and said, this reward stuff doesn't work. Doesn't work at all. I'm like, oh, what'd you try? He goes, well, I told my daughter once that if she didn't tic for a week, I would buy her a car. She couldn't last a day. I'm like, no, she probably couldn't. But let me tell you, let me have you give a different bet. Do this bet with her. Bet her that if she does her competing responses, her exercises, every time she feels the urge to tic, and she does that in the next week, then she gets the car. I guarantee she'll be driving around in the car. Okay? She might have tics, but she'll have that car too. Because what we do in reward system is we try to reward them for working the treatment, for being compliant with the treatment. We really don't get too hung up on whether the tics are happening or not. It's kind of the same way as, if you have a diabetic child, what can you hold them responsible for and what can you not hold them responsible for? Well, if you have a diabetic child, think of diabetes, there is no cure for it. The effective management strategy is essentially all behavior therapy. Check your blood sugar, learn how to take your insulin, learn how to eat right, learn how to exercise, all that kind of stuff. And you can hold your child responsible for doing those things. You can get mad at them and give them time out if you find them hoarding candy bars, for example, or not following their insulin checking regimen or something like that. You can do that, but you would never punish your child for having a bad pancreas. Your pancreas is shot. You go to timeout. The same way you wouldn't punish a child for having tics, but you could hold them responsible for not using their management strategies. Okay. In any case, the sample that we tested for the children, we had about age of 12 of these 126 kids, mostly male, average IQ, 40% were on tic-reducing meds in a very stable family environment. Most of them had Tourettes. They had a lot of other diagnoses too, ADHD, OCD. These are full-blown current diagnoses, not past diagnoses. After 10 weeks of treatment, we looked at the percent of kids who were clinically improved. And what did clinically improved mean in this study? It meant very much improved or much improved. Very much improved was a CGI, Clinical Global Impression Score, of 1 or 2. That meant they either had virtually no tics and no impairment, or their tics were greatly down from baseline, and the impairment was much lower, tic-related impairment. So that's CGI of 1 or 2. There was a third category of a CGI of 3, and in this study, CGI of 3 meant there was improvement. So there was some benefit. It just wasn't enough for us to say, yeah, there was some real power behind this change. Okay? So what did we find? At the end of 10 weeks of treatment, 8 sessions, 53% of the kids in CBIT were improved versus 19% of the supportive therapy kids. Now this difference here between here and here, that's the effect of behavior therapy. In here is the effects of feeling like you're going to get help. In here is the normal passage of time where tics will generally get better anyway. In here is the idea of learning more about tics and becoming more comfortable with it as a family. All those kinds of effects are built right into here. Beyond this is the effect of behavior therapy. All right? Their tics got less severe on a tic severity measure compared to the supportive therapy. They had less tic-related impairment in the behavior therapy condition relative to the supportive therapy following 10 weeks. And when we look 6 months later at who responded initially, we found some interesting findings. 86% of those who were responders at the end of 10 weeks were still responders at the end of 3 months. 87% of those who were responders at the end of 10 weeks were still responders at the end of 6 months. So what does that tell us? That tells us if you get benefit, and 53% do, that there's just a really good chance that the benefit's going to stick around. It's not going anywhere. This lasts.
Is that with the annual?
No. This is, whatever the kids do, we don't follow it. If some do it, some don't. Some keep doing the exercises, some don't. Yeah. But that's 87% maintenance. Tick reduction. Significant reduction in tick severity for those who responded. So if you responded, your tick severity stayed low 6 months later. Your impairment stayed low 6 months later. Yeah.
What if they stop doing the exercises? Do the tics come back?
Sometimes not. Yeah. And either way, we're okay. Because again, we don't profess to cure anything. We're teaching a tick management strategy. That's what we're teaching. And you can use your management strategies or you cannot use your management strategies. The more consistently you use them, the easier it will get, the better it will get, and there's a chance you may never have to use them again. But maybe you will, and then you have to get right back on the horse. Yeah?
Is there any part of this that would benefit a child that does not have the premonitory urge, like who's too young?
Well, we generally, we don't do it this way for younger kids, all right? We usually start around the age of 8 or 9 where we'll do this full protocol. You can do stuff with kids that are a little bit younger. Okay, so for example, I have a son who is a little ticky. He has some facial tics and stuff like that. And my wife knows what I do. She's a master's level psychologist. And so and my son's 9. So she, one day when he was probably like 5 or something like that, I noticed him walking, or he was around the house and he was going, woo, woo, starting to drive us nuts a little bit. And I never was sure whether it was a tick or if it was just kind of him being excited, because it was always at an exciting time when he did this. And he would go, woo, woo. It was driving my wife and I crazy. And so we knew enough not to react to it, not to say anything to it in case it was a tick. And finally I came in one day from work and I was walking in the door and he was walking down the steps, walking down, and, whoop. Hi, Daddy. What you doing, Sullivan? Mommy told me whenever I felt like I had to do this or when I did it, I should do breathing until I don't feel like I have to do it anymore. Okay, good job. It stopped. It never happened again. Okay. And another example, I was coaching him in baseball, and I'm watching him from the dugout, and he's on first base. And I saw him out in the outfield on the first base, and he was sitting there like this with his glove. This is when he was about 7. And he looks up, it's a nice day out, and I'm in the dugout watching him, and I see him look up at the sun, and he goes, I'm like, I haven't seen that one before. I'm watching. Come here, buddy. What you doing? I don't know. Which is true. They never know what they're doing. They're just kind of hanging out and existing. What are you doing, buddy? I don't know. What I saw you do that. What was that? He goes, I don't know. I felt like I had to look at the sun. I felt like I had to do it. Oh, okay. Hey, whenever you feel that again, next time, just put your glove down and hold your hand at your side and make your neck a little tight like this. And just do that until you feel like you don't have to do it anymore, okay? All right, Dad. Trots back out to first. Looks up like this. Looks at me, and I'm like, did that a few times, and that was it. Never happened again. Can we do it with younger kids? It looks different. It's not quite the same the way we do it maybe in session, but I think you can. They don't always have to have the feeling. They don't always have to have the urge, and this can work. It's harder to treat a little bit sometimes if they can't become aware of the urge, or the urge just isn't there. The truth is, though, even younger kids, most of them have the urge if you know how to find it. The problem is that isn't that the younger kids don't have an urge. It's that they don't really have language to describe what that is. They don't know how to talk about it. Okay, so there's a piece of that. We looked at something else too. What happens to other behavior problems, other issues that kids with Tourette's often have if you treat their tics, if you successfully treat their tics? Because there's some concern in different parts of the literature. People who write like notes or popular press books, sometimes you'll read these kinds of things. There's not much data to support what they say, but they write about these concerns that if you teach kids to stop their tics like this or reduce their tics like this, that it'll have negative side effects. And some of the negative side effects is that they'll get more anxious, they'll get more stressed, they'll have more trouble paying attention, they'll get angry at you, those kinds of things. And so we wanted to look at that. And what we looked at here is this is the child behavior checklist. This is a big measure of all problem behaviors in children, like a global measure of behavior problems in kids. And what we found was that in kids whose tics got greatly reduced as a result of behavior therapy, the kids who got CBIT successfully, 6 months later, all of their behavior problems were lower. They just had lower behavior problems. When we looked at the specific types of behavior problems, if they got successful benefit from CBIT, if their tics were successfully reduced as a result of CBIT, then 6 months later they were less anxious. 6 months later they were less disruptive. So there seems to be some positive spillover. If you get significant benefit from this, there can be significant benefits in other areas beyond just the tics. Now, what about comparison? How does this stack up? Yeah.
Do you have any insight about children who would have gotten benefit and then stop practicing?
Sometimes their tics will come back. Sometimes they don't need to do the practices anymore because there's just no urge to tic anymore.
And if they're still ticking and they're just not getting on board with the treatment?
Then their tics might go back up. I mean, that could happen. If the it cycles back up again, it can definitely do that. Yeah. So let's look at how this compares to medication. These are a couple of the common medications that you'll hear talked about in terms of treatment. These are atypical antipsychotics. Kind of like the mid-level of treatment. Usually you'd start with something like clonidine or guanfacine. If that doesn't work, then you try to go to an atypical like Risperdal, something like that. We wanted to look at, what's that? Yeah. We compared CBIT to, the CBIT trial, the child study got published in the Journal of American Medical Association, and the adult study is coming out shortly in the Archives of General Psychiatry. So those are the two different studies. The sample size for our CBIT trial was 126, and this compared to one of the best risperidone studies was 34 subjects versus 28 subjects for ziprasidone. You can see there are a lot smaller studies when we talk about some of these medication trials. Our control groups, and then we look at how much reduction in tic severity scores did we actually see. CBIT showed a 31% reduction in tic severity scores, 36% reduction for Risperdal, and 35% reduction for ziprasidone. Essentially, we've got a treatment here in terms of amount that it brings tics down that's roughly similar to Risperdal, the atypical antipsychotic. So like the second level of medication that you would try. That seems to be what we have in terms of how much it brings tics down. Now, we also did something unique in that we looked at side effects. So every week we measured the side effects of treatment. Did any of these problems crop up for you in the last week? And what we found, and I have 4 highlighted in yellow here, what we found was that there were no differential side effects in the two treatments. So the treatment where we were teaching them to control their tics was no different in terms of side effects created than the treatment where we didn't ask them to do that. All right? And the 4 I have yellow highlighted are those that are there because sometimes in popular press books, sometimes in articles that you find, or sometimes in chat rooms you read on the internet, you'll hear these complaints made about any kind of tic suppression type of treatment. Okay? And sometimes people misunderstand behavior therapy as a tic suppression type of treatment. That behavior therapy will make you more anxious and nervous because you're always trying to focus on your tics and it's making you so upset and uptight about it. And what we found here is A, that was a very rare occurrence, and B, it didn't happen any more in one condition than the other. So there was nothing about behavior therapy that made you more anxious or nervous. That behavior therapy will make you disruptive because you'll feel like you're so ticky you'll just have to kind of get disruptive and angry and aggressive, and that doesn't happen. It'll make your tics worse. The more you pay attention to tics, the more you try to stop your tics, it'll actually make them harder to control. They'll get worse. There's some concern about that. That doesn't happen. And that doesn't happen, and it happens, in fact, even a little bit less in behavior therapy than in the control condition. Right? Tiredness and fatigue. This tic treatment is a very tiring, fatiguing kind of thing, and it's just going to wear you out. Well, the truth is that didn't happen either, and it didn't happen any more in one condition than the other. If anything, it happened a little more in the condition where we didn't try to get them to control their tics. Okay. So we have a treatment that's fairly effective and what appears to be fairly safe. So then the question comes, if behavior therapy for tics is so promising, then why are we just hearing about this as a brand new thing? Why is this such a novel thing when habit reversal, for example, has been around for 40 years now? Why is this for the first time coming out as something like it's new? Well, I think there are a few things. First of all, we have some problems that we have to address as a field. We have to address the issue of dissemination. We have to understand how we're going to teach therapists to do this. That's not necessarily an easy thing to do. It's not like we have drug reps, for example, running around teaching psychologists how to do behavior therapy. That does not exist. There is no good way to get psychologists really well trained to do a therapy. You know, we haven't figured out, we haven't done the research to figure out how to get that to happen yet. And so there's that problem. There's the resource problem. It's not cheap to train one-on-one psychologists over and over and over and over again to try to get them to do this. That's a problem. Drug companies have millions of dollars to push out to get, you know, physicians to teach them how to prescribe new medications, you know. And so that training is kind of funded and built in to sell the product. You know, nobody gets money off making this product. It's just something that's out there and it's got to be picked up. So the TSA has been trying to figure out ways to get therapists to do this and to train them. They're doing it in a couple different ways. There's a partnership that TSA has with the Centers for Disease Control. How many of you have been to one of those talks in your region? Anybody? One of these local TSA talks? I bet you have, actually. But there's that, and that we do a lot of talks for patients. We do a lot of talks for therapists. And what we try to do with the therapist is to teach them that this treatment exists, to teach them that there are effective treatments like this out there. We also, the TSA this year has started something called the Behavior Therapy Training Institute. So is anybody who's been to one of those here? I know there are a couple people floating around. Maybe they didn't come to this session because they just heard it all 2 days ago. But we've had 2 behavior therapy training institutes that people pay to come to. So they pay like $500. We have a 2-day workshop with them where we train them and then do follow-up consultation with them to make sure that they're doing it right. And so far we've had like 50 people come through and do this training. So these are professionals from all over the country who want to learn more about how to do this. And so we're trying to do things that we can to disseminate and get people to know how to do this treatment effectively, but it's really not an easy thing to do. And it's going to be a little while until we can ramp up the number of people who are actually really well trained to do this kind of thing. We also have a referral problem in that the neurologists and pediatricians are usually the first people to get the referrals here. And a lot of times they simply don't know that this exists. And if they do know it exists, they don't know where to go to send patients to get it. And so we've got to do a lot of work here to, A, teach them that this exists and that this is a treatment option, and then B, we've got to fill that up with, backfill that with people who are really well trained that they can have access to. There's also a bias, I think, a residual bias. It's diminishing every year, but there's a bias against psychological treatment for Tourette's. Some of the people who are older in the Tourette's community remember that treatment before Haldol, before antipsychotic medication, wasn't a good thing. It was a very kind of dark place for a person with Tourette's in terms of treatment. Good treatment options didn't exist. The treatment options that were out there were often blaming of the parent or the child, and there was a lot of kind of bad vibes coming out of psychological treatment at that time. You know, you go to the psychologist, and the psychologist said, "Oh, it's just a nervous habit. You know, just learn how to relax, and you'll be okay." You know, that's not what we're saying for sure, and that probably wasn't good advice then either. But a lot of people who are older have felt a little mistreated by psychology in some ways in the past, and because there are a lot of psychologists who don't know much about this disorder. So there's some bias against psychological treatment that we have to overcome to get behavior therapy more acceptable, I think. And there's also a few beliefs about the negative effects of behavior therapy. Some people just, in fact, some physicians actually still write about these negative effects. The truth is there's no data behind the negative effects, but people continue to kind of promulgate the negative effects. Let me give you a couple examples. There are a couple examples of concerns people have about behavior therapy. First is this idea of rebound effects. The idea of rebound effects involves people getting very concerned that if I teach my kid to suppress my tics, and isn't that what behavior therapy does? If I teach my kid to suppress their tics, after they stop suppressing them, their tics are going to return and explode. It's like tics are a steam cauldron, and if I block all the vents, the steam's just going to build up, and then something's going to explode. Okay, there's that idea. All right. There's another idea too, another criticism of behavior therapy, and the criticism goes something like this: Behavior therapy really is just, it's like, whack-a-mole. You're sitting there and you hit one mole and another mole pops up, and it's just, all you're really doing is chasing. So you bring one tick down, it's just going to make other ticks worse, right? So we wanted to look at these things. We've tried to test both of these ideas. In one study we did, we looked at, tried to test a rebound effect. We had 7 kids with Tourette's, and we had them come into our experimental room. We had them sit down in our room, and it's a 3 meter by 3 meter room with observation mirrors on it. And we told them, this little box in front of you, I don't have a picture of it, there's a box about this big. This little box in front of you is a tick detector. It's got motion sensors in it. You see the little camera? It's been programmed to detect just your ticks, okay, because we had just done some big interview beforehand. And this machine can count your ticks for you, all right? Now, we're going to ask you to do some different things. The first thing I'm going to ask you to do, called baseline, is I want you to sit there and feel free to tick. Don't try to stop them. We're going to leave the room. You can tick. The tick detector will be counting you, but that's all, okay? So we leave the kid in the room. We come back in and we say, now this time the tick detector is going to do something a little special. Now I want you for the next 5 minutes to try as hard as you can not to have ticks. And for every 10 seconds you go without a tick, you're going to get a little token. The tick detector is going to shoot out a little piece of money for you, all right? It'll be worth a few cents, all right? We're trying to get them to suppress their ticks because we want to see whether that makes the ticks worse. Then we come back in and we say, okay, for the next 5 minutes, the tick detector is not going to be giving you any money anymore, and we don't want you to stop your ticks anymore. We just want you to feel free to tick, all right? So now what we're testing is rebound. Does suppressing your ticks make them worse after you stop suppressing? Okay. Here's what happened. In these 7 kids, 50% of the time they were ticking at baseline. They were ticking a lot, right? When we reinforced them for suppressing their ticks, gave them money for not having ticks for 10-second periods. This isn't treatment, by the way. This is just an experiment. We would never treat a kid like this. This is just an experiment. It dropped to about 15% of the time. We reinforced the suppression of ticks, and their ticks dropped to 15% of the time. Now, if there's a rebound, if suppressing your ticks causes a rebound, what should happen? Go above baseline, not just return to baseline. Return to baseline is normal. That's normal functioning. What happens? Well, it actually doesn't even quite get back up to baseline. And then we ask them to suppress again. What happens? It goes down again, just like it should. And then we look for the rebound. And again, it doesn't happen. In this study, there showed no rebound effect. Now, some people have said, but this is 5 minutes. Make them suppress for a long time. What happens then? Well, we did that in the second study. We had kids come in and we had them suppress for 5 minutes, followed by a chance to look at the rebound where they weren't suppressing anymore. We had them suppress for 25 minutes, followed by a 5-minute period where they were allowed to tick if they wanted to, and a 40-minute period of suppression, followed by a 5-minute period where we checked to see if they had rebound. And this is what we found. And they all got all durations. They all had to suppress the same number of times. At baseline, they were ticking about 8.5 times a minute. When they suppressed for 5 minutes, they went down to 2 times a minute. The rebound following that went up a little bit. It looks like it went above baseline, but statistically that's not significant. That was just kind of fluctuation in the data. When they suppressed for 25 minutes, they were able to do that too. What happened after 25 consecutive minutes of suppression? You'd expect the rebound to go even higher because they've been suppressing longer, and it doesn't. In fact, it starts to go back down. When they suppress for 40 straight minutes, they can still do it. And when we look to see what happens after 40 minutes of suppression, that's when you'd expect the rebound to be highest, but it's actually not. In fact, it even goes down a little further. So what do we conclude from this? And these are just 2 of the studies. We've done a number of other studies just like this, and we never find this. We've never found rebound at all. So what we conclude is that there probably just isn't this rebound phenomenon. Now, why do people keep thinking there's a rebound phenomenon? Here's why people keep thinking there's a rebound, okay? The reason people think there's a rebound is because every parent sees something like this. My kid doesn't tick at all at school, and they must have been holding it in all day at school because they haven't ticked at school. But when they come home, my God, they explode, So they put the logical conclusion together of they've been suppressing their tics all day at school. Why? Because they're not there at school. And then they come home, and his tics are much worse. So it must have been because he was suppressing, right? Well, these data say probably not, actually. What's probably happening in this, the home school thing is probably where are all the reinforcers for not having tics? School. Where are none of the reinforcers for not having tics? Home, because you're doing what you should do. You're creating a safe, supportive environment. You don't care if they tic at home. You're not supposed to care if they tic at home. That's the good thing. So what happens? They don't tic at school because the contingencies say don't tic at school. They tic at home because it's okay to tic at home. And so you see that contrast. And that's what you're seeing. And it's easy to interpret that as suppression causes an increase, but it doesn't. Okay? The evidence says that that's not actually happening. Right. What about the symptom substitution idea? To study this, we actually did something interesting. We treated vocal tics in kids. We had 5 kids. We treated their vocal tics, but not their motor tics. And we did that intentionally. Our hypothesis was that if we bring the vocal tics down, then if the symptom substitution hypothesis is true, that really all behavior therapy does is push tics around, then as we bring the vocal tics down, the motor tics should actually increase, right? Because we're bringing down one set of tics, the other set of tics should go up, if the symptom substitution hypothesis is true. So we treated all of the children's vocal tics in one 1-hour session and 2 half-hour booster sessions. We did it on the vertical dash line. That was the day the 1-hour session happened. Each data point is an in-home videotaped observation of the child. We set a video camera up in their room where the parents said that the child was most likely to tic, and we left them for 20 minutes. We came back, grabbed the videotape, and went out to score it. All right. We did this multiple times a week. And what you find, each panel is a different child. What you find is that for Don, the first kid, you see a significant reduction after treatment in his vocal tics. His motor tics, which we didn't treat, also decreased. And he maintained it 3 months later. John, significant reduction in his vocal tics, no change in his motor tics, and he relapsed 3 months later. Ben, significant reduction in vocal tics, no change in motor tics, maintenance at 3 months. Raoul, significant reduction in vocal tics, no change in motor tics, and maintenance at 3 months. And Frank, treatment didn't work for Frank. Okay, so what do we conclude from that? We conclude that this is a treatment that doesn't just push symptoms around. Okay? It's not that you're going to push one set of symptoms down and other symptoms will reemerge as a result of that. Now, that's not to say a kid with Tourette's won't get new tics on behavior therapy, because of course they will. New tics come and go. That's part of the syndrome. New tics will always emerge during any treatment. That's the nature of the disorder. Okay. Habit reversal. In conclusion, habit reversal is a promising treatment for Tourette's. We still need a lot of things. The studies that we've done have been under very tightly controlled conditions in big clinical trials. That might be very different than how this treatment performs out in the real world, so to speak. So we need big studies kind of looking at how does this perform in the real world. We need to understand predictors of response to treatment. Does this work as well for kids with ADHD? And it doesn't, actually. Kids with ADHD make everything a little bit tougher to treat from a behavioral perspective. Does it work as well for kids with OCD? Yes, it does. Does it work as well for kids with anxiety disorders? Yes, it does. Does it work as well for kids on tic-reducing medication? Maybe not. And we're going to talk about that as we learn more about it. Not today, but as we learn more about it, we might learn how to medicate children and use medication with this intervention more effectively. How does this work a year out, 2 years out, 3 years out? We have to figure that out. What's actually causing the change here? I've been starting to hear about some neuroscience studies that show that there are some neural changes that are associated with effective response to this treatment. So if you do well on this, something in your brain has changed. And so that's interesting. That'll be interesting to see how that pans out in the next few years. We also need to overcome barriers to implementation. How do we make sure we get this treatment out to people who can use it? We've done a couple studies looking at whether we can deliver this treatment on telehealth, teleconference equipment, Skype, those kinds of things. And what we're finding is that this actually works pretty well when you use teleconference equipment. So people don't have to travel so far to get some of these things if the right equipment's in place. Looking at developing computerized therapist training packages, educating appropriate care providers about behavior therapy. Ron?
Like any other program, this obviously doesn't work for everyone who tries it.
Nope.
Is there a test that you have to meet with each individual to decide if it'll work for them?
We don't have the test yet. There isn't a test that you can do. We're starting to try to come up with characteristics that would predict whether they'd be more likely to respond or less likely to respond. So, for example, if you don't have ADHD, for example, you have probably a 68% chance of responding to this treatment. You have a really good shot. If you have a child without ADHD and has tics and they go through this treatment, there's a really good shot that this is going to work for them. It drops when you have ADHD. It gets lower. So it kind of, eventually we'd like to find profiles that would say, you're a really good candidate for this. You're going to struggle for this, or maybe you need to have this done in a different way, kind of thing. Yeah, yeah. In the back. Yeah.
Are all types of ADHD not receptive to this? For example, if you have someone who has inattentive ADD, have you checked to see whether?
Again, we don't have enough data to say that one way or the other. We're not even solid on the ADHD yet. That's more my clinical impression than it is anything else.
Okay.
Yeah.
Mine's kind of a two-part question,
Yeah.
maybe a little bit related, but my son, there's absolutely no way that he would even set foot in, to go 10 times, 90
Yeah.
minutes, 90 minutes. So do you think it's a little skewed towards kids that are more compliant? Yeah.
Absolutely.
And the second part of my question is that my son's tics have sort of come and gone on their own. We had a coughing tic that lasted a week,
Yeah.
and without any treatment. So I don't know how this question works, but how can you say that the treatment works when a lot of the tics sort of come and go? And I know that's true for other.
The reason I can say that is because that coming and going part of what makes tics better was captured in the supportive therapy control condition, because they too had that same amount of time. So if it was just that tics were coming and going, then there would have been no difference between the groups, because there wouldn't have been anything extra about behavior therapy. Do the kids have to be compliant? Well, sure. I mean, I would never take a kid ever. I've sent parents home where their kid says, I absolutely don't want to do this. My mom's making me do this. I won't treat them. I'll send them home because this won't work. And the same way, I would never force a pill down the kid's throat if they didn't want to take it. I mean, I just wouldn't. And I don't think it's right necessarily to think about it that way. So compliance is always an issue. I mean, kids could be cheeking a pill and spitting it out later if they don't like it. I mean, so of course, it's not going to work as well if somebody's not compliant. Yeah.
Is there a website to find providers of CBIT, or how do you go about finding?
What you need to do, the TSA is starting to maintain a list. They've got a couple different lists. They've got a list of everybody who's been through the TSA CDC CBIT lectures. So that's a broader list. That isn't necessarily; those aren't necessarily people who will know how to do it well. Those are people who have heard about it, maybe have tried to pick it up and tinker with it. And then your probably more secure list is they've got a list of people who have been through their Behavior Therapy Institute, and that institute is it's only got it will have about 50 people on the list after a couple months. But just call them and see if there's anybody in your area. Where are you located?
We're in Grand Rapids, Michigan.
Grand Rapids. Actually, you're fairly close to me if you can get across on the ferry. But there's really not anybody on that side of the state that I know of. There's somebody in Detroit. Shauna Tyndall is a psychologist who knows this stuff pretty well in Detroit. But I can't think of anybody in Grand Rapids. Yeah.
I've got a son who's 12, and at 10 and a half we started with the CBIT, and the biggest problem we were having, and maybe, is that he just says, I just cannot find the urge. I don't know, it just happens.
Yeah.
And trying to do the detective work, it's just been really hard on him, and it just gets him really frustrated.
Yeah.
Now, Dr. McKinley was showing his site where, play detective,
Yeah.
and I think I'm going to, showing that,
Yeah.
he can really get into that, and maybe that will help him.
Yeah.
But we started with the CBIT, and then all of a sudden his tics started. I mean, he was at such a high peak with his tics, and then the tics just started going down.
Yeah.
Where they're not as noticeable. Of course, he always says, "Mom, you're not inside my brain."
Yeah.
They're there.
Yeah.
And so it's like, so I want to maybe reintroduce CBIT, and we're lucky we're in Louisville. We've got somebody
Yeah.
that he's working with. We've just sort of moved it into other type of therapy to
Yeah.
deal with anger management and things like
Yeah.
that. But just try. How do I give him? And do we do the study and just as his tics, if he has a tic, deal with it that way? Like how because he just keeps on saying, I can't find that urge.
Well, he may not have one. I mean, it
Yeah.
really may not be there. Not every tick has an urge, so that's not unusual necessarily. And also keep in mind, I mean, this doesn't work for everybody. I mean, at some point, if you've given it a good go and it doesn't work, then it doesn't work. I mean, not all medications work for people, so you try different medications. I mean, you have to kind of take that approach. That's why I say if you hear somebody selling you this will work for you kind of thing, they're either naive or or lying to you,
Maybe
you know.
look at more at the habitual thing where it's like he's working with his hands, find something else
Yeah.
for his hands to do.
Yeah.
or-
Yeah, in the back.
Has there been a comparison study on the effectiveness with adults compared to children?
Yeah, I'm sorry I didn't present the data on adults. It wasn't a direct comparison, but we did the same study with adults. And what we found was roughly 40% of the adults responded. Okay, now 53% of the kids responded, 40% of the adults responded. So the response rate was lower, which basically means the longer you have this condition, the more difficult it's going to be to respond to this. Not surprising, frankly. I mean, adults are the people for whom the tics didn't naturally go away. And so it's probably a more chronic, tough to treat condition with anything. So, yeah.
Do you know anybody personally in Alaska?
I was just in Alaska. I just was there like 2 weeks ago. Talk to me afterwards, and I'll try to put you in contact with this hospital that did it, did the training. Yeah, it was one of these CDC things, so they have some people up there who might be interested.
I also have a child who's reluctant to do anything like this. Is there any videos on the web where, I could show my child what this would be like?
How old is he?
She's 12.
I would actually, Duncan just walked in, but I would actually have her read Duncan's book. It's called Nix Your Tics. It kind of gives kids an idea of what this is going to look like and what this feels like. And usually it's written in a way that kind of motivates kids to think about this. And that's kind of where I'll start if a kid doesn't have much interest in thinking about it at the beginning. Yeah.
The next session is going to be a demonstration.
Yeah.
What's your feeling about bringing your child in to watch the demonstration?
It's fine. Yeah, it's fine. Yeah, put it back.
What was the name of that book again by
Duncan?
Duncan? It's called Nix Your Tics.
I always screw it up. I either say Nix the Tics or Nix your Tics, but I know it's Nix and Tics. I just don't remember the middle.
In the Ontario government, the Ministry of Canadian Youth Services requires me to say at this point that I'm here representing them this weekend, and they have no affiliation whatsoever with that book. Conflict of interest.
Other
You can
questions?
find it on my cottage.
Yeah,
You
yeah,
mentioned about anxiety and OCD.
yeah.
Is there a part of this that's treating the obsession of the compulsion?
Probably not directly. I mean, indirectly perhaps, but probably not directly. What the question was, is there a part of this that's treating comorbid OCD, the obsessions part of OCD? And I said maybe indirectly, but probably not directly. But yeah.
I have a more practical question.
Yeah.
What would the cost be of the treatment?
The cost of the treatment, it depends on where you're at. It depends on who's administering it. You could go, a psychologist in my area with insurance billing would probably be about $80 an hour, and there are 9 hours of treatment. So what is it, $720? And then booster sessions as needed. So it just kind of depends on how it goes. So before we wrap up, I want to go over a few things that I want to make sure you hear out of this talk. The few things that I'd like you to take home from this. Actually, there are things I don't want you to take home from this, because I always get scared when I do a talk like this to parents because I don't want them to misunderstand what I'm saying. So a couple things. First, I'm not saying in this talk that all children with tics need or could benefit from behavior therapy. Okay? A lot of the kids that I see, I won't treat, even with behavior therapy, because the tics aren't a problem for them. The moms and dads are seeing a tic, it looks bizarre, they're nervous, the kid doesn't want help, the kid is fine socially, everything's good. All they really need is some education about this, and they need to know that they're doing the right thing, and that all they need to do is just let the tics go, and they'll probably take care of themselves. Okay? That's that's a good way to go still for a lot of people. It's only when the tics are a problem, they're really causing a problem, that we need to think about intervention. The other thing is, we're not saying that because behavior therapy works, Tourette's must be a learned problem or something being done intentionally by the child. Everything you heard me say, you could easily misinterpret as, oh, so you're saying my kid learned how to do this, or I taught them how to do this, or they're trying to do this. No, not at all. I'm not saying that. I'm saying the environment influences the brain, and the brain has a problem with tics, and it's making the brain problem a little bit worse. Okay? But it's not an intentional thing. Behavior therapy for tics sounds extraordinarily simple. It's not. It's hard, and it's a lot of work. It's hard for the therapist, it's hard for the kid. The work can pay off, but it is work. I'm not saying that behavior therapy works for everyone. I've said a couple times, if somebody tries to sell you a treatment that works for everybody, there's something wrong, because there is no treatment that works for everybody. If you heard me say that rewarding a child for having tics as a treatment is good behavior therapy, you heard something wrong, because that's not what I'm saying. You can't buy your kid a new car if they don't tic. That won't work, all right? I'm not saying the child is trying to do the tics to annoy you, frustrate you, or get your attention. And finally, and the most important thing, is the failure to get benefit from behavior therapy. I'm not saying that, and I don't want you to hear that if a kid doesn't benefit from behavior therapy, that somehow reflects that the kid isn't trying, or that they're lazy, or whatever. 53% of the people who give their best effort to this don't respond. Or only 53% who give their best effort respond. There's a chance you go through it and it won't work. You have to be okay with that. Just like you try a new medication and it may or may not work. You just have to see. Same kind of thing. If the kid doesn't respond to behavior therapy, that doesn't mean they failed. That doesn't mean they're lazy. It doesn't mean they haven't tried hard enough. And that's a really important message to understand. Even the best treatments don't work for everybody. So I think that's it for our time. We'll resume at 11. So have your break. Thank you.